We're going to see the peptic ulcer disease. Peptic ulcer disease can be usually to Helicobacter pylori. This could be an ulcer on the gastric, in the stomach, so a gastric ulcer, or on the duodenum, a duodenal ulcer. Most of the ulcers will be due to Helicobacter pylori, but also the ulcers can arise for Zollinger-Ellison syndrome, as well as for biliary reflux and drug-induced ulcer like NSAIDs. Let's remind the protective molecules or protective hormones for the mucosa. So we have gastrin, bicarbonate, mucose, and prostaglandins. Gastrin increases the proliferation of cells on the proliferative zone. So there will be more cells, and gastrin is protective. Bicarbonate is protective because it's opposite to the acid. Mucose protects the cell damage from the hydrochloric acid, and prostaglandin increases the blood flow to the stomach, increases the bicarbonate secretion and the mucose production. So we produce the prostaglandins due to the cyclooxygenase enzyme, and the cyclooxygenase enzyme is blocked by NSAIDs. So each patient taking NSAIDs is at increased risk for developing gastric or duodenal ulcers due to this point of the prostaglandins. Now, the factors that weaken the wall are histamine, biliary salts. Biliary salts because they decrease the blood flow and increases the permeability. And the histamine decreases the blood flow, so produces ischemia, and then the wall is debilitated. So now, a patient with Helicobacter pylori will present with the same symptomatology as a ulcer, as the non-Helicobacter pylori, but a patient with alcohol use has increased risk of developing Helicobacter pylori duodenal ulcers, not NSAID related, but due to Helicobacter pylori. Yes. Alcohol and smoking. As a rule of thumb, we have non-healing ulcers or recurrent ulcers. In our differentials are the patient is using NSAIDs and we did not detect them. The patient has alcohol or smokes, because these two things delay the healing of the ulcer. Or the patient is non-adherent to the treatment. Alright, so first the presentation. Presentation of a gastric ulcer is pain with meals, because when the food comes into the stomach, there is liberation of the hydrochloric acid, and so the ulcer hurts more. And the duodenal ulcer presents with pain 2 to 3 hours after food. So at the moment of food, the patient feels nice, because when there is secretion of the hydrochloric acid due to food intake in the stomach, then secretin also promotes now that the counteractive molecule be secreted, that the bicarbonate be secreted from the pancreas, and so the duodenum receives the hydrochloric acid from the stomach, but also a lot of bicarbonate by the pancreas, and so this is why duodenal ulcers are less, or the pain is less severe while the patient is eating. So it will be severe in fasting, like 2 to 3 hours after the last meal. So the presentation aids a little bit in the diagnosis, if it is exactly at the moment of food intake or 2 to 3 hours later. You can remember as gastric ulcer hurts more, or the pain is greater with meals. And with duodenal ulcer, the pain decreases with food intake. Now the Helicobacter pylori testing will be either with urea breath test or stool antigen. Because stool antigen has high specificity and sensibility, but urea breath test only has high specificity, not sensibility, or low sensitivity. So we would use this more as a test after the treatment in order to see if we already eradicate the bacteria. We can also do serology, but serology, remember that, cannot distinguish between past and recent infection. So the first diagnosis test would be a stool antigen most of the times. Now we can do endoscopy. Endoscopy will distinguish between by the gold standard for distinguish this, and the most accurate test for peptic ulcer disease is endoscopy. In endoscopy, we will see if it is a gastric ulcer or a duodenal ulcer. Most of the time, we need to biopsy the gastric ulcers, because with endoscopy and biopsy is the gold standard to define if the gastric ulcer is malignant or benign. Malignant lesion will look like the ulcer and peeled up of the adjacent mucosa. And the benign ulcer would be smaller and would look like a punch hole and shiny mucosa around. So this is benign, this is malignant ulcer, but anyway we need to do biopsy, and that's the gold standard. The duodenal ulcers are not routinely biopsied because they are less common to become malignant or to be malignant. The presentation, we already see that is different, as well as the risk of becoming malignant or the risk of being malignant, and we need to do the endoscopy anyway. The treatment could be, if it is mild symptomatology, we can give antacids. Antacids, remember, we have aluminum hydroxide, magnesium hydroxide, and calcium. Remember that aluminum hydroxide, the adverse effects are constipation, hypophosphatemia, proximal muscle weakness, osteodystrophy, and seizures. And for magnesium hydroxide, the adverse effects are diarrhea, hypophosphatemia, hypotension, and cardiac arrest. So we usually combine aluminum and magnesium hydroxide because one produces diarrhea and the other produces constipation. If the symptoms are a little more than just mild, then we give the antihistamine to blocker receptors, like cimetidine or ranitidine. And if it is more severe, we give the proton pump inhibitors. This for just normal ulcer most of the times. Now, if the patient has the Helicobacter pylori stool antigen positive, because this can distinguish between recent and past infection, it will only be positive with recent infection. So if the patient was positive for this, then it is due to Helicobacter pylori, and so the treatment is triple therapy. The triple therapy includes amoxicillin plus clarithromycin plus a proton pump inhibitor, most commonly omeprazole or lansoprazole. If a patient has allergy to amoxicillin, then we can change it to metronidazole. So metronidazole, clarithromycin, and the proton pump inhibitors. We will give this treatment for 10 to 14 days, even though we can extend it in order to more healing of the ulcer. And after the treatment, we need to check again for Helicobacter pylori eradication. Now we can use the urea breath test because it would be very specific. So we can do the urea breath test, and if it is negative, Helicobacter pylori has been eradicated. In case that the patient continues with the symptomatology, then we can give, that is if the patient was resistant to this treatment, then we give tetracyclines plus metronidazole plus bismuth sulfacylate, and sometimes we can add also the proton pump inhibitor. If the patient continues to be resistant with this, then again endoscopy. Remember that the gold standard for diagnose peptic ulcer disease, for distinguish if it is a gastric or duodenal ulcer, and the diagnosis also to the gold standard to the diagnosis of Helicobacter pylori ulcer is with biopsy, endoscopy with biopsy, as well as that endoscopy will also reveal if the patient has already symptoms or lesions of chronic Helicobacter pylori infection, so a chronic gastritis, or if the patient has already a metaplasia due to the chronic gastritis, due to the chronic inflammation, or if the patient has developed the mactoma. Alright, so after this, we will do endoscopy if the ulcer was resistant to any one of these. The prophylaxis of gastric ulcer, of peptic ulcer disease will be in patients with burns, head trauma, ventilation, hyperventilation. Most of these would need prophylaxis. So that is a patient with head trauma, and remember that the head trauma can increase the intracranial pressure and so activate the vagus nerve, the parasympathetic pathway, and so promote the liberation of hydrochloric acid. So we need to protect these patients, and we give prophylaxis with proton pump inhibitors. Now, complications. Complications include perforation, bleeding, and obstruction. Obstruction will be seen with a gastric or duodenal ulcer, a gastric ulcer that is on the pylorus, and duodenal ulcer very proximal duodenal ulcer. This will be obstruction, and the treatment is surgery. Perforation. Remember, everything that perforates does not bleed, and everything that bleeds does not perforate. In perforation, the patient can have abdominal tenderness, sometimes warding, due to peritonitis. The perforation is most commonly seen on anterior duodenal ulcers more than posterior duodenal ulcers, and this can lead to free air under the diaphragm, so pneumoperitoneum. When we suspect the perforation of the gastric ulcer, first step is a abdominal X-ray. If we cannot see the perforated ulcer, then we go to the CT scan, and the CT scan is let's say the gold standard. But remember that if there is a posterior duodenal ulcer that has been perforated, we will not see the air under the diaphragm because the duodenum is a retroperitoneal structure. Now, in a bleeding ulcer, we need to do serial hematocrit to be monitored if the patient continues bleeding, etc. Certainly, the first thing that we do with upper gastrointestinal bleeding is a nasal suction. And the IV fluids. Remember that everything that has bleeding on the gastrointestinal tract, the blood is irritant, so we need to give proton pump inhibitors. And the endoscopy at the end to rule out continued bleeding. And here, if the bleeding was not managed with just endoscopic procedure, in that case we will need to do surgery. But what can be managed with endoscopy would be by epinephrine injection or clipping. Now, the indications for surgery. Surgery indications include perforation, obstruction, bleeding that was not controlled by endoscopic procedures, and recurrent ulcers. We can do a vagotomy, that is cutting the vagal nerve in order to decrease the secretion of hydrochloric acid in refractory ulcers. Now, the algorithm to refractive ulcers. First, we need to check the gastrin levels. Gastrin levels. This is the algorithm for recurrent or refractive multiple ulcers. First is check the gastrin levels in picograms per milliliter. This could be below 100, could be between 100 and 1000, or could be above 1000. If it is less than 1000, then there is usually no peptic ulcer disease. That would be because the hydrochloric acid suppresses the gastrin. So here at least not would be not Zollinger-Ellison syndrome, that I forgot to tell about that. Zollinger-Ellison syndrome is a tumor of the yeast cells. The yeast cells are the cells that secrete gastrin. So a tumor of the gastrin secreting cells produces a lot of gastrin, and so gastrin goes to parietal cells, and parietal cells produces a lot of hydrochloric acid, and so the patient can develop multiple ulcers. But so this patient has increased gastrin and increased hydrochloric acid. The increase in the hydrogen ions would lead to a low pH. So here we don't have an increased gastrin. Here we have an increased gastrin, but we don't know if the pH is high or not. So here, next step is to check the pH. If the pH is below 4, that would be Zollinger-Ellison syndrome. If it is above 4, then we are talking about a reason by which we have increased gastrin and the hydrochloric acid is decreased. So we will think about pernicious anemia. In pernicious anemia, there are a type 4 autoimmunity, that is lymphocytes are destroying the parietal cells that secrete hydrochloric acid and the intrinsic factor of the mucosa. So when we suspect pernicious anemia, we will take the antibodies to the parietal cells and to the intrinsic factor of the mucosa that are not the cause. The cause is the damage by the T lymphocytes, but these antibodies aid on the diagnosis. Then, if we have gastrin levels from 100 to 1000, again check the pH. If it is above 4, we think that pernicious anemia, and then check the antibodies. If it is less than 4, we are not going to assume yet that it is Zollinger-Ellison syndrome because the gastrin was not very elevated. So we will do the secretin test. In secretin test, the normal response to secretin test is that the gastrin levels will decrease. But in a patient with a gastrinoma, that is Zollinger-Ellison syndrome, the gastrin levels will not be suppressed. So a negative secretin test would be suppression of the gastrin levels. This is normal. And a positive or abnormal test is no suppression of the gastrin levels. And so this would be Zollinger-Ellison syndrome. So Zollinger-Ellison syndrome is diagnosed either by a high gastrin levels despite the hydrochloric acid, so with a low pH, or after a positive secretin test. But in order to have the secretin test, we first need to have a gastrin level between 100 and 1000, then a low pH, and then now we do the secretin test. For Zollinger-Ellison syndrome management, that is a cause, rare cause, but is a cause of recurrent multiple ulcers, the treatment would be, if we can resect the tumor, that is if there are no metastases, then we resect the tumor, surgery. But if there are metastases, then we just give proton pump inhibitors. We cannot resect the tumor. And we will give proton pump inhibitors to high doses because, one, we need to decrease the hydrochloric acid secretion, and the other, the ulcer is there, we are not removing it. The ulcer can bleed, and remember that each bleeding, the blood can irritate, and so we want to prevent that irritation with giving high dose proton pump inhibitors. Now, the way by which we're going to look for metastases could be, usually we begin with a CT scan or MRI, but the sensitivity is just 60 to 80%, so if we don't see any metastases on this test, we cannot exclude metastases. So we will go to the next step, that is non-nuclear octreotide scan, that is also called secretin receptor scintigraphy. And this, let's say, that is the gold standard for finding metastasis. If we find metastasis, we cannot resect the tumor, and we just only give proton pump inhibitors. And if we don't see metastasis, then we can resect the tumor. So this was Soligny-Ellison syndrome, and it's a cause of recurrent multiple ulcers, usually that are found further to the or distal to the duodenal bulb, usually in the jejunum or the pancreas. So the management of peptic ulcer disease could be only with antacids, proton pump inhibitors, H2 antagonists. If the peptic ulcer is due to H. pylori, then we give the triple therapy, clarithromycin, amoxicillin, and proton pump inhibitors. If the patient has the allergy to amoxicillin, then we give metronidazole. If this doesn't work, then we give tetracycline, metronidazole, and bismuth. If this doesn't work, we do reendoscopy. Remember that the most accurate test for peptic ulcer disease, either for distinguish between gastric and duodenal ulcer, to do the diagnosis, to check for Helicobacter pylori, is with upper endoscopy. And the complication could be perforation or bleeding. Bleeding would be most common with the posterior ulcer on the duodenum, because this can lead to bleeding of the gastroduodenal ulcer. And for the gastric ulcer, if it is on the lesser curvature of the stomach, then the left gastric ulcer can bleed. A ulcer also located in the posterior duodenum, remember, that can perforate, but if it perforates, then doesn't bleed, and we will not see the air under the diaphragm. For perforation, remember a abdominal X-ray. If we cannot see it, then we go to the CT scan. And patients with posterior duodenal ulcer can also have pancreatitis. And for recurrent multiple ulcers, then we need to do the algorithm of finding the levels of gastrin, and based on that, if it is high or if it is low, and if we have the pH below or above 4, and in which case, in which the gastrin levels is moderate elevate, then we can do the secretin test. And depending on the diagnosis, we will have Soligny-Ellison syndrome, and then we need to look for metastasis to see if we can resect this tumor or not.